Hematuria means blood in the urine. Hematuria is basically of two types: gross hematuria, that is visible under eye, and microscopic hematuria, that is visible under microscope. Common causes of gross hematuria are urinary tract infection, stone, and malignancy, and other rare causes are Alport syndrome, hemophilia, sickle cell anemia, immunoglobulin A nephropathy. Microscopic hematuria usually caused by inflammation of the kidney, ureter, bladder, or prostate. Benign prostatic hyperplasia, glomerulonephritis, stone, malignancy may also cause microscopic hematuria. There are some benign conditions that may cause hematuria, such as strenuous exercise, menstrual cycle, sexual activity. Hematuria may be termed as terminal, initial, or total hematuria, whether it occurs at the end of the micturition, beginning of the micturition, or during the whole micturition. Sometimes hematuria is associated with pain, and sometimes it is painless. Renal cell carcinoma usually presents with loin pain and discomfort, hypertension, anorexia, and weakness. Diagnosis usually made by renal biopsy. Renal cell carcinoma is resistant to chemotherapy and radiotherapy in most of the cases. Immunotherapy such as interleukin 2, interferon alpha, and biological therapy sometimes show some response. Bladder carcinoma usually presents with lower abdominal pain, dysuria, hematuria, and urinary retention. Diagnosis made by cystoscopy and biopsy. For early stage of bladder carcinoma, the options are transurethral resection of bladder tumor and partial cystectomy. Sometimes intravesical BCG vaccine is given as immunotherapy, and chemotherapy is given for advanced stage of bladder carcinoma. Prostate carcinoma usually presents with urinary frequency, urgency, dysuria, hematuria, and urinary retention. Diagnosis is made by serum prostate specific antigen and prostate biopsy. Surgical management are radical prostatectomy and transurethral resection of prostate. Radiation therapy are sometimes needed in association with surgery. Hormonal preparation are used to inhibit androgen activity, and sometimes bilateral orchidectomy done. Targeted therapy are sometimes given to destroy cancer cells. Cryotherapy and ultrasound are used for localized killing of cancer cells. Chemotherapeutics are sometimes used for castration-resistant cancer. Bisphosphonates are used to reduce bone destruction. Urinary tract infection usually presents with urinary frequency, urgency, and burning sensation of micturition. Diagnosis usually made through urine examination and urine culture. Preferred treatment options are cefuroxime and clavulanic acid, amoxicillin and clavulanic acid, nitrofurantoin, and levofloxacin. Benign prostatic hyperplasia. Usual symptoms are urinary frequency, urgency, and incomplete voiding. Diagnosis made by digital rectal examination and ultrasonogram of the prostate. Tamsulosin and dutasteride are used to relax the sphincter and reduce symptoms. Surgical management are needed when symptoms worsen. Alport syndrome is a genetic disorder characterized by hematuria, sensorineural deafness, and eye problems. Diagnosis made by renal biopsy and genetic study. There is no specific management for Alport syndrome. ACE inhibitor and ARB are used to slow the progression of the disease. Dialysis and renal transplant are ultimately needed. Hemophilia is an X-linked recessive disorder, causes defective clotting factor synthesis. Abnormal bleeding occurs at various sites such as nasal bleeding, hematuria, joint bleeding, skin bleeding, and diagnosis usually made by clinical feature and clotting factor study. Patient is treated with protein factor concentrate. Polycystic kidney disease is an autosomal dominant disorder, causes multiple cyst formation at the kidneys. Usual presentation is low in pain, hypertension, weakness, hematuria, and sometimes urinary retention. Diagnosis made through renal ultrasound, renal CT scan, and renal biopsy. There is no specific management for polycystic kidney disease. Tolvaptan is considered to slow the progression of the disease. Dialysis and renal transplant are ultimately needed. Anticoagulant used for different diseases may cause bleeding problems such as hematuria, nasal bleeding, and skin bleeding. Anti-cancer drugs sometimes cause bleeding problem. Glomerular diseases are characterized by proteinuria, microhematuria, oliguria, hypertension, and periorbital edema. Some glomerular diseases that may cause hematuria are immunoglobulin A nephropathy, anti-neutrophil cytoplasmic antibody-associated nephropathy, rapidly progressive glomerulonephritis, Goodpasture syndrome, post-streptococcal glomerulonephritis. Diagnosis usually confirmed by renal biopsy. For immunoglobulin A nephropathy, the management is ACE inhibitor or ARB, omega-3 fatty acid, steroid, statin, diuretics, and ultimately dialysis may be needed. For anti-neutrophil cytoplasmic antibody-associated nephropathy, cyclophosphamide along with steroid is a good combination for induction of remission. Plasma exchange is needed in severe cases. Rituximab sometimes given in resistant cases. Methotrexate and azathioprine are used for maintenance of remission. Lupus nephritis is treated with mycophenolate mofetil with steroid or cyclosporin with steroid. Rituximab sometimes used. Rapidly progressive glomerulonephritis is treated with methylprednisolone, cyclophosphamide, and sometimes rituximab. Thank you for watching.